Hello, my name is Mary Mitchell, and I will be doing my clinical case presentation on Mr. A.A., 42-year-old Hispanic male. Chief complaint. Mr. A.A.'s chief complaint was right knee swelling and pain for 1 week. He also experienced an episode of chest tightness with palpitations, dyspnea, and diaphoresis on exertion. History of present illness. Mr. A.A. states he had been experiencing right knee swelling with associated pain for 1 week. He denies any traumatic event causing the right knee pain. He also states that when he was trying to get up with his walker last night, he experienced an episode of palpitations, tachycardia, and diaphoresis with chest tightness. He states he took 1 sublingual nitroglycerin, and as soon as the tablet dissolved, the discomfort went away. Patient denies any recent episodes of chest pain and denies any radiation of the chest tightness. Medical history. Medical history includes hypertension, hyperlipidemia, type 2 diabetes, AFib, myocardial infarction, and heart failure with a reduced ejection fraction. He also was hospitalized 1 month prior for pneumonia. Surgical history is positive for an ICD. It is a Medtronic device. Family history. His father did have diabetes and his mother was positive for Alzheimer's. Social history. Mr. A.A. denies currently smoking, but states he quitted smoking 20 years ago. He had smoked 1 pack a day for 10 years, so he has a 10-year pack history. He states that he does have an alcoholic beverage once per year on his birthday, denies any illicit drug use. He is a retired football coach. Mr. A.A.'s home medications are as follows: lisinopril 10 milligrams PO daily, aspirin 81 milligrams PO daily, atorvastatin 40 milligrams PO daily, furosemide 40 milligrams PO daily, Imdur 30 milligrams PO daily, Eliquis 5 milligrams PO BID, allopurinol 100 milligrams PO daily, Coreg 25 milligrams BID. Review of systems. General. Mr. A.A. does report fatigue, but he denies fever, chills, or night sweats. Cardiovascular was significant for chest tightness, palpitations, dyspnea, and diaphoresis with exertion. He does also report bilateral lower extremity edema that progressively worsens throughout the day. He denies any cramping or claudication with ambulation. Patient also does have the known history of heart failure with reduced ejection fraction with his ICD placed. Respiratory. Patient does report dyspnea and diaphoresis with exertion, and he was recently hospitalized for pneumonia. Musculoskeletal. He does report right knee swelling and pain, but denies any decreased range of motion to the extremity. Physical assessment. Vitals are as follows: temperature of 98 oral, blood pressure of 172 over 103 with a mean arterial pressure of 126, respiratory rate of 20, heart rate of 98, oxygen saturation of 97% on room air. He did have a chest x-ray that showed central vasculature was prominent. No consolidative infiltrates or effusion was demonstrated. He did also have an x-ray of that right knee for the swelling. There was no fracture or focal bone lesion, and there was no soft tissue abnormality. His labs are as follows: WBC of 9, H&H of 13 and 42.5, platelet count of 281, PT 14.5, INR 1.10, PTT 29.6. His glucose was 470 on admission, hemoglobin A1C of 14.3. Sodium level was 132, potassium of 4, chloride 95, BUN of 24, creatinine 1.63, ALT 16, AST 9, TSH 0.76. His lipid panel did show cholesterol level of 215, HDL of 36, LDL 127, triglycerides of 260. Troponin was 1.42 and a BNP of 3539. General, Mr. AA was a pleasant 42-year-old Hispanic gentleman. He was resting comfortably on the stretcher when I went and saw him. He was a very good historian. He was overweight, but he reports that he has been losing weight with regular exercise. However, over the past week, due to his knee pain, he had been less active. But again, he denied any traumatic event that caused that knee pain. Cardiovascular S1, S2 were noted, but they were distant. There was no splitting, murmurs, or gallops. Bilateral radial and dorsalis pedis pulses were +1. He did have +2 pitting edema to bilateral lower extremities. Respiratory, he did have diminished breath sounds to bilateral apices, and rhonchi were noted to bilateral bases. No rales were noted, no cough was noted. Musculoskeletal, he did have 5 out of 5 strength to bilateral upper extremities and the left lower extremity. The right lower extremity was 3 out of 5 strength, though, due to that knee pain. He did have a knee brace on to that right knee, and then he reports using a standard walker with ambulation. So my problem list is as follows. So we need to rule out a non-STEMI because he had that elevated troponin. Next would be to rule out a meniscal or ACL tear because the right knee pain and swelling. And then last would be heart failure exacerbation because he did have the elevated BNP. So my plan of care would be to admit him to a telemetry unit with telemetry monitoring, do a repeat EKG in the morning to assess for new ischemia or infarction, echocardiogram to assess for worsening heart failure, order a Lexiscan stress test to assess for exertional cardiac ischemia. If the Lexiscan results were significant, we can consider doing a heart cath. Consult cardiology for the heart failure exacerbation and elevated troponin. Daily labs of CBC, BNP, MAGFOS, PT, INR, PTT, BNP. Do a couple more sets of cardiac enzymes, so Q6 hours times a total of 3. Lasix IV BID, but monitor his renal function and adjust the dose as needed. PTOT to evaluate and treat for that right knee. We would need to get a hold of his ICD rep to see if his device was MRI compatible, and if it was, I would do an MRI of that right knee to see if he had a meniscal or ligament tear. If we had any significant findings on the MRI, we would get an ortho consult. 2-gram sodium diet with a 1.5 liter fluid restriction, strict I's and O's, daily weights, and continue all his home meds, but I would increase the atorvastatin to 80 milligrams QHS, and then we're going to switch the Lasix from PO to IV. Thank you.